Aibowan, and a very good evening to all our viewers here on TV1. I'm Dr. Dilshan Fernando, and this is your weekly dose of wellness here on Healthline. And a warm welcome to all our viewers joining in via YouTube as well. Today we'll be talking about syncope. That term might not ring quite familiar with most of our lay viewers joining in. But have you had an episode of sudden fainting and you would have recovered and didn't know what the cause was? Or do you know someone that had undergone this sort of episode? These might be due to a very sinister cause, or it might be a normal cause as well. But today we'll be talking in depth about this topic and focusing mainly on the cardiogenic causes of this syncope. And for this, we have invited a very charismatic cardiologist to the TV1 studios this evening. He is none other than Dr. Kishan Silva. A very good evening to you, sir, and thank you for joining us here on Healthline.
Thank you, Dilshan. Absolute pleasure, and a good evening to our viewers. Thank you for having me.
So, first and foremost, I know we said that we'll be focusing on the cardiogenic causes, but as an introduction to our program, can you elaborate what is syncope?
Yeah, Dilshan, that's actually very important, the definition. That is the faint. When we say syncope, grand word, but it's actually the faint. But in this case, it's when we refer to syncope, we refer to sudden, transient loss of consciousness with complete and spontaneous recovery. When we say complete, you wake up without any weaknesses or anything, any residual symptoms, and spontaneous is you do not have to revive, and the reason being lack of or cessation of blood flow or reduced blood flow to the brain. So, all that is part of the definition. When we discuss further, you will understand why it is important.
So, basically it is a sudden loss of consciousness due to the lack of blood supply to the brain, and you recover spontaneously.
You recover. So, because it effectively exclude the other certain other causes.
So, talking about syncope, we said that there can be varied causes for it. So, if we can broadly categorize into what these causes are.
So, like in the definition, if it is there is lack of reduced blood flow, can be various reasons. So, those are the things that you can focus on. It's rarely severe blood loss or dehydration can cause reduced blood pressure, which might be critical enough to have a syncope. Then we have some people have postural syncope. When they from lying down to sitting up, the pressure can drop enough to have a syncope. More often it is just a dizziness, but sometimes it can lead to the faint. We have a very important cause called the NMS, neurally mediated syncope. That is the one probably you have heard with the certain triggers, emotions, pain, standing for a long time, etc., can in certain people, the people more vulnerable to it, that can trigger a sudden drop in the blood pressure, and that can again beyond a critical point can faint. And third one that we will go more in depth is where cessation of heart activity can cause loss of blood flow to the brain, and you can have a syncope.
Now, before we delve further into the topics, I think we should address this about this posture. Now, you said changing from lying down position to sitting down. I think it would be best to give our viewers some advice if they are indeed experiencing some symptoms as such, maybe a bit of dizziness, what they should do.
That's right. It's a very common thing. Well, fortunately, it's not common to faint due to the postural change. So, I am sure a lot of viewers have experienced a dizziness, where most often from lying down to sitting up or standing. When you are lying down, the pressure is naturally lower, and that is fine because the brain is down, and the blood pressure is enough at the point at that time. And when we all suddenly sit up, the pressure has to adjust immediately to the sitting position, which is slightly higher than when you are lying down. That adjustment can take a little time. So, patients or people who when they feel a dizziness, they know that the pressure is not enough. The risk is if say you are in bed, you get up, you sit up and you feel a little dizzy, you disregard it and you stand up and walk, you might aggravate the situation and might have a faint or fall in between somewhere. So, the advice would be, if you know you are one of those rare people who have postural, what we call hypotension and possibility of syncope, you sit up on your bed, wake up properly, and when you feel that the dizziness is gone, you take, say you are going to the washroom or whatever, you get up and go.
Right. Now, continuing on with our conversations, we said we'll be focusing more on cardiogenic or effects this syncope given rise by cardiac causes. And as a cardiologist, I think that would be your area of expertise, that would be your domain.
Right.
So, about syncope, the cardiogenic causes of syncope, what are these causes?
Yeah. If I may, can I just mention a little more about the neurally mediated before getting on, because that is probably the greater part. As we were discussing before, cardiogenic is important, but it's less frequent. In the neurally mediated, the commoner term is probably vasovagal among among our fraternity, is that people do faint. You have heard of people fainting during parades, during school assemblies.
Yes.
In our injection rooms, whenever they take blood, at least one faint per day. That could be due to the pain or the fear of it. So, their trigger is a fear or a pain. Mothers faint when their children, something happens to their children. Those are strong emotions. Coughing, laughing. So, effectively, all these triggers can lead to a sudden drop in the blood pressure. So, initially you feel you are going to faint. So, all these people have that story. I felt this, I saw the chair, I thought I will go and sit, but before I could make it, I fainted. Several times it has happened to me, but I have managed to sit down or lie down and prevent a fall. So, that is there in that story. You realize, this is a trigger, and they also know the trigger. So, it is very easy to differentiate that from the cardiogenic. What happens in the neurally mediated is the pressure drops, and beyond a certain point they will faint, and then they wake up on the floor and say, I knew exactly where I was, etc. The cardiogenic is different in the sense that something happens with the heart. It's most often it's a heart rhythm, either slows down too much or pauses long enough, or it goes, heart rate is extremely fast, where the pump becomes ineffective. In both cases, not enough blood flow going to the brain, and the patient or the person faints. Most often the story is that they never saw it coming. So, that is why it's important, when I suppose you will want to know later on, that when we listen to the story, we are very, very careful to listen to that part, how it started.
So, like you said, it can be neurally mediated, it can be cardiogenic, there can be various triggers for it. Now, as a cardiologist, when seeing these type of patients, you said the story matters, their history, how they present to you matters. So, how do you differentiate, okay, this is something that is neurally mediated, or this is probably a cardiogenic cause? What sort of story would they be telling you?
Yeah, for us, Dilshan, the story is actually the most important part of in assessing one of these people who have fainted. Fortunately, most of them, at least most of them, come to us referred by other physicians, where they have excluded other possible causes, from a stroke to blood sugar drop, etc. So, when they come to us, one of the main thing is, if having a witness is very useful. Most often the patient falls, nobody is around, he or she looks around, sees a table, sees a carpet, sees a pool of water, and says, I tripped on that, I slipped on that. So, they reconstruct for it to make sense. It does not make sense to a person to have just fallen. It makes a lot of sense to us later on, but for the person, they reconstruct the story. But we backtrack a little bit and we realize actually it was not anything or tripping or a slipping, that this probably was more in line with the cardiogenic. So, story, we really reconstruct the fall in our minds. So, there is always a lapse. They remember having come to the kitchen, poured the tea. Next thing, their story is they are on the ground. So, there in between there is something missing. So, we realized that this person did not have a prior warning or had a prior warning, in which case the patient will tell us. So, that is what helps us in differentiating neurally mediated syncope from cardiogenic. Cardiogenic, the warning, if at all, is very, very short. So, that is an important factor.
Neurally mediated syncope or fainting episodes, they will get a bit of a warning and
That's
a bit
right.
of time to adjust and try to break their fall or go and sit down somewhere.
That's
but
right.
if it's cardiogenic, they will not have that warning.
Yes, if at all it will be very short, they might say it was blackening for them, or they have their own ways of expressing, and next thing they know is that they are waking up on the ground.
Any other symptoms and signs they would experience in this scenario, sir, other than the fainting?
In the cardiogenic, most often not. Syncope is the main chief complaint. We listen to see whether they have had palpitations, because if the heart slowed down, most likely they would not have that. But if the heart started racing fast, they probably would not have fainted immediately. So, they may have felt that the heart was racing, or they call it palpitations. Rarely chest pain if it is a ischemic event, anginal event that led to the syncope, then they might say. So, we ask around that as well.
Now, as a cardiologist who headed a syncope center in Stockholm and now a cardiologist practicing in Sri Lanka, when a patient presents you said more often than not referred from someone else, what would be your approach to diagnose what is indeed wrong with these patients?
Yeah. So, as I said before, we will first see if the other causes have been excluded and it sounds like a syncope, then we try to differentiate between neurally mediated, postural and cardiogenic. And if it starts sounding more and more cardiogenic, then we start thinking of the cardiogenic causes. Have had a heart attack before or a heart disease before, have had similar episodes before. We have of course, then we have the other tools to go by. I mean, ECG is very useful. An absence of any changes on an ECG does not rule out cardiogenic, but it is useful if there is something on the ECG. And then we move on to doing other more advanced studies, like an echocardiogram also gives us information. Yeah.
So, now a patient suddenly faints and falls. It can be a very traumatic, very scary experience. But are there various risk factors which might predispose towards this condition, something that they can avoid? Is there something as such?
See, most often it is the first faint that brings them to us, and there could be underlying causes which they have not known. If somebody has had a heart disease before, they will recognize those symptoms. But most often they actually go to other specialities. Because of the fall, they have broken limb or hurt their head or somewhere, so they end up with other people. So, very often we do not have symptoms that warn them.
Right. So, if you, our viewers, have indeed experienced episode as such that we have been describing here in our program, and you haven't been able to pinpoint a cause, it might be worthwhile consulting cardiologists to see if the cause for that has indeed been cardiogenic. Now, moving on with our discussion, sir, how common are these syncopal episodes? Is it very common in your day-to-day practice?
Well, yes, it is a bit of a natural selection, because a lot of patients are sent to me. So, I see probably at least 1 or 2 in my practice per day. But if I just walk into an emergency unit, I would think we have at least 1 or 2 per day in the bigger hospitals for fainting of varying causes.
Right. Now, we know that cardiac disease is, if not present from birth, cardiac disease is tagged as disease of the older ages. But in this scenario, which type of demographic does it affect more? Is it the old ages, or is there no such discrimination, no such determination of age?
No, it is commoner in the old age group in where cardiogenic is concerned, because it is most often related to the electrical system of the heart. So, with age, that is also an aging electrical system. So, we see more pauses, more electrical disturbances in the older group. But we also see certain structural heart disease, enlargement of the heart, we call it hypertrophic cardiomyopathy. We have now lately I've been able to identify a lot of genetic causes.
Okay.
You may have heard of Brugada syndrome, long QT syndrome. Those lead to very rapid heart rate, and that also can cause. So, now we are probably seeing even the, where we may have missed out earlier, we are seeing even the younger people coming in with syncope.
Right. Now, when you see a patient who has had such a syncopal episode, are there any particular drugs that they might be taking which can lead towards this condition?
Very true. Yes, there are drugs that alter the electrical system of the heart. Some simple drugs that we do not actually think of, which we use very commonly in our daily practice. We use beta blockers, we use so-called calcium channel blockers, we use diuretics that can affect the salt balance, which can in turn affect the heart rhythm. And then we have, where the genetic causes are concerned, there are certain drugs that predispose you to those conditions. When you have those conditions, these drugs can affect the heart and cause syncope.
So, if you are experiencing this type of episodes, it might be worthwhile to get your prescription rechecked by a properly qualified medical practitioner. And as we always reiterate here on Healthline time and time again, do not self-medicate. That might lead to very severe causes and very bad outcomes as a patient. Now, so you said you will be using ECG, echocardiogram, and if you cannot find any problem with those investigations, are there any more advanced investigations that you would employ?
Yes, we do. I mean, if the story is very suggestive of what we call a cardiogenic syncope, we will not stop at not finding anything on the echo or the ECG. We would try to increase our chances of catching something by doing a 24-hour ECG. That is called a halter. Sometimes if we are not lucky enough, we might not even pick it up on the 24. We might extend it for a few more days. If the suspicion is very strong that this is cardiogenic, we also have implantable small chips. You are fainting once in 3 months. So, you might do 10 halters and miss, but we know there is something behind. So, there is an implantable chip that will go on for 2 to 3 years, implantable loop recorder as we call them. And if you faint within those years, the heart rhythm is inside this little device which we can read off a computer. I also want to mention a test called the tilt table test. Okay. That is a test where we actually can provoke a faint. It sounds terrible, but it's done under very controlled circumstances, and one of us is always present. When we provoke that faint, patient wakes up, of course, after the faint, where we have been having the ECG continuously monitored and the blood pressure monitored. So, we know exactly what happened at the time of the faint. But what is more important is not what we see at that point, because we figure out whether it was the pressure dropping or whether it was the heart slowing down or stopping. Patient wakes up and says, this is exactly what happens to me out there. So, you know you have reproduced that same faint, but now you have figured out what the reason was. So, you do not have to go on doing other tests like EEGs and CTs of the brain, because most often people are worried about the brain when they faint. Yes. And think less about the heart or the blood pressure dropping, etc. So, that is another important test we have. In a rarer case, we would do what is called an electrophysiological study. That is where we provoke or trigger fast rhythms that can be a cause behind these faints.
Now, sir, we were talking about various investigations that you as a cardiologist can employ to find out the exact cause. Now, a patient has been diagnosed to have cardiogenic syncope, and it might be a very terrifying experience for them, especially if they face these scenarios over and over again. Is it common for it to recur if there is underlying pathology in the heart? Is it common for it to recur? And if so, what do they need to look out for, and what sort of precautions can they take? Because these falls can end up with very severe consequences.
Yeah, Dilshan. So, like you said, if it is a diagnosed cardiogenic syncope, actually we are very happy because we will have a very good solution hopefully for that. So, it is not the diagnosed ones that we are worried about, because those we can patch up nicely and may never ever fall again. So, that is why it is so important for us to find these people and find the cause behind them. It is not always that we find a cause the first time round. So, they have had a faint, we have almost certain it is cardiogenic. We have done, I think we discussed about the Holter, the 24-hour ECG. We have done one, we have done several, we have missed out on all, probably had a second fall very similar to the previous one, no warning whatsoever, traumatic fall, wake up on the floor, coffee is there, newspaper is here, person is on the ground, can't figure out what happened. 2 falls is too much for us. We know there is a third one coming.
Yes.
So, we won't stop at halters, and if we don't find, we will probably do the implantable chip or further, because all we want is an ECG recording if possible at the time of the fall. You understand how difficult that is.
Yes.
Right?
It has to be recorded exactly at the time of the event.
So, there is absolutely no way a patient can do that. So, we have to have these devices and things to pick up. So, we are lucky to catch a person on a halter. They have a fall once in 3 months, 2, 3, 4 times a year, and it is totally unpredictable. But the halter can give us a warning. Patient may not have fallen during the halter, but there is a pause long enough for us to figure out where the problem is, but the patient has not felt anything during that recording, but that is enough for us. So, halter does give us information even if the patient has not had a fall during the recording. If we have done everything, but we still have not found, that does not mean there is nothing.
Yes.
There is something that we just have not found yet. So, for those people we are very concerned. Can they go swimming alone in a pool? Can they go out to sea alone? Can they be driving? So, those are the risks of having a sudden faint that is not that's been established and figured out and treated for.
So, moving further on this topic, sir, is there any precaution that they can take at home to make sure that if they do indeed have an episode, that they are not the consequences are not so bad as it could be?
Yes. So, if my what we call a gut feeling is that this is cardiogenic and it is just that I have not found, I would always, till I find, we will look, while we are doing our workup, I would say you go to the washroom, do not lock yourself, you can fall in there. Hanging around places, top of the staircase, balconies, you have to be careful. Going out, swimming alone, and then always this sensitive topic of driving. Even that I would want stopped, or if at all stopped, till we figure the cause.
It might be a big inconvenience, but considering the alternative outcomes,
yes,
definitely I think that's good advice for a person who has not been properly diagnosed yet, but experiencing these type of fainting episodes.
I think people are very sensible, like you said, it's a very frightening thing. So, they are not, when we give that kind of advice, more often than not they say, yes, we understand, and so it's not very difficult, though it sounds to you and I that stop driving. So, but if it has happened to you where you have had a so-called blackout, people are careful.
Now, a person has a blackout. When should they consider coming to a cardiologist?
I think if there is no cause, if you first definitely go to your doctor, that's where you should start, and he or she can't thinks it's cardiogenic, even if it is the first fall, we would like to see those people, because there can be an underlying obvious reason which can be rectified, and that's it, no more falls. So, no point waiting for the second, probably more critical, more fatal fall. So, if there is suspicion that this is cardiogenic and not anything else, we would like to see those patients.
So, first and foremost, be followed up by their family physician, and if they do feel like a cardiologist opinion is required, they would refer such patients to you.
Yes.
Right. Now, what are possible treatment modalities that are available for these patients?
Yeah. So, if we have a ECG tracing during the faint, during the fall, or there are on the ECG tracing or the 24-hour ECG, we see there are pauses which can be in fact longer than what we actually see. There are so called telltale signs on a recording that tells us this is going to come back. And if the patient has had a faint that sounded like a cardiogenic, it may require a pacemaker, for instance.
And so that is an implantable device.
Sorry, yes, it's an implantable device. It's all inside. You don't. It's a very simple procedure to implant a pacemaker. It's not open heart surgery or anything. We just find a little vein in the shoulder region, and with that, with the help of X-rays, we can place our electrodes very nicely where we want, and then the pacemaker will see the heart activity beat to beat. If there is even one beat missing, the pacemaker goes in and gives that beat. So, patient does not know that the pacemaker is working, only thing that he or she knows is that he or she has not fainted since. So, it is a fantastic simple solution if we do find the cause. Other causes are, like you said, Kishan, just taking out some of the medication. Electrical system is weak, you are weakening it further with medication. You just take them off and patient has never had a faint since. So, there can be simple things that we can do. Rarely you may have heard of the pacemaker that can in fact give electrical shock. We call it an implantable cardioverter defibrillator, ICD.
Yeah.
But that is to prevent potentially fatal, very fast, so called tachyarrhythmias.
Now, how is the prognosis or the outcome of these patients if you have diagnosed a cardiogenic cause for these blackouts or fainting episodes? Is the outcome fairly good, or how does that
In
work?
most cases, I would say it's very good, Dilshan. I mean, you put a pacemaker, it's almost the end of the story. They can go back to their driving, they can go back to their normal activity. I have people with say for implantable pacemakers, they are playing tennis, golf and swimming around, and they've gone back to their normal lives, extremely happy because they have never had a faint, and the faint has been very debilitating for them before. People with structural heart disease and fainting, we say hypertrophic cardiomyopathy, we say trying to exclude competitive sports and some medications may suffice, or in a rarer case we might offer them a more advanced device. So, prognosis is most often, depending of course on the cause, is good.
So, that is good news for our viewers. If you are experiencing these blackouts and if your general practitioner has not been able to identify a cause, you may present yourself to a cardiologist, and if they can find a cardiogenic cause, according to Dr. Kishan, the outcomes are more often than not good. So, now sir, with the time constraints that we have, we are coming towards the end of this episode of Healthline, but before we wind up, what would be your advice, your take home message for our viewers, if especially those who are experiencing these type of symptoms?
Yeah, I think the most important that, like we discussed, is that after a faint, you go and see your physician, the one that you are used to going, because he or she will know the background. Very often we find that it is at the third or fourth fall that they have come, and they may have had some fatal, traumatic falls with a lot of injuries. So, my main thing here would be that even if it's a faint that doesn't sound like your faint that you had all your life from your school days, and this is different, that you go and see your family physician and you, make a case there. And if nothing is found, that you will be referred further, because like we said, solution can be quite simple and permanent.
And there you have it, Dr. Kishan De Silva in conversation with us regarding syncope or fainting episodes. So that brings us to the end of this episode of Healthline. Thank you very much, sir, for joining us this evening and educating our viewers on this very rarely talked about topic, but something that most of our viewers might be experiencing at least once in their lifetime. So thank you, sir, for joining us.
Thank you for having me, Dilshan.
So with that, before I take your leave, once again, I would like to remind our viewers, we are still not out of the woods with regards to COVID. Omicron is here, it's still mutating, and numbers are slowly but surely rising. So please continue to practice your social distancing etiquette, wear your face mask, sanitize yourself, maintain the social distancing, and keep yourself and your family safe. With that message, I take your leave from this episode of Healthline. Until we meet you again next week with your weekly dose of wellness, this is me, Dr. Dilshan Fernando, signing off, wishing all our viewers Ayubowan.